Pleased to see some others here. So thank you for coming. Do we have any actual apologies, Lindsay?
Yes, we do have apologies. We've apologies from Lucy Allen, Andy Appleyard, Jim Austin, Beth Fleming is covering, Paul Brookhouse, Chris Clayton, Robin Jewis, Gino Di Stefano, Siobhan Horsley, Dean Howes, Mark Powell, Maria Riley is covering, Clive Stanbrook, Sue Ann Lim, Kathy McLean, Councillor Holmes and Councillor Wright said she may be coming but she'd be late.
Okay, thank you very much for that. As you just very quickly, because the first item is going to be presented by, well, item number 5 actually, substantive item will be presented by Chris Viner, and he does need to leave at 1:25 because of the NHS discussions happening nationally. I would just say that we have undertaken the review of the partners' attendance at the board, and actually it's quite interesting that the attendance is actually very good, apart from one or just 2 organisations essentially. So there's really excellent engagement with the Health and Wellbeing Board. We are sending out emails shortly to remind people of their attendance and thank them for attending, and for the few people who do not attend at all, we're also going to ask them to review whether they do wish to remain members of the Health and Wellbeing Board, because we are considering also whether other certain partners may want to join the board. I would take this opportunity very briefly to remind all partners that they can send in items for the agenda. We do have a forward plan. Generally, those items need to align with the health and wellbeing strategy, which, as you know, at the moment is undergoing revision, and we'll look at that briefly later on. If you are thinking about items for the agenda, I would remind you that our remit here in Derby, because we're a unitary authority, is quite broad. So we're not equivalent to the County Health and Wellbeing Board. We do look at broader determinants of health. We do analyse health patterns and health strategies in accordance with the integrated care strategy, but we also have reports from our local activities and local actions in trying to intervene on health, because we don't have anywhere else to report that to as a unitary authority, and that is what you will get with a unitary authority. So we're a small city. People in the room know the city. We're small geographically, and for many of us it seems like a small village. So if we seem to have a detailed knowledge of what we're talking about, and it's more detailed than it may seem as so-called strategic, that's because we're not talking in abstractions for most of us in this room. We live here. We often know the people we're talking about. So I think we have a nice sort of interaction between general themes and specific projects and specific issues. And if you do have things that you would like to see on that agenda, then you need to forward them and have a discussion with Alison Wynne about that. I would like to thank Margaret in particular for her assistance recently. I invited Margaret as the Vice Chair to come along and sit in the agenda setting meetings with me, and she has done that, and I really welcome her input. So we'll both be sending out these emails that come from both of us regarding attendance. So thank you very much for that. Do we have any late items? We don't. Do we have any declarations of interest? No. Are we all happy to accept the minutes of the meeting on January the 16th as a fair representation of the meeting? For those people who are actually here, I see a nod from the councillors. I see a nod from Amjad. Thank you very much. So we'll accept and note those minutes. Thank you. And thank you to Lindsay in particular for obviously doing the heroic job of writing the minutes. What I am going to do very quickly just now, don't worry Chris, it won't take too long, is I'm going to, because what we have now created an action log for the Health and Wellbeing Board, and we didn't discuss in advance where we'd quickly look at this action log, but it seems to me that now is an appropriate time to do it, just as we've looked at the minutes. So the action log is not aligned with your minutes. If you have paper, it's the very last piece of paper you have. If you don't have paper, it's the very last section of the Health and Wellbeing Board Forward Plan and Action Log, item 11. So I'm just going to look at those actions now, run through them with you briefly. The first one is regarding inclusion of Year 9 school nursing survey in relation to gambling, and that's in progress, and that should be coming to the next meeting. Is that right, Alison? I'll just quickly run through these. If anybody wants to make any comments, please stick your hand up. So that's in progress. There's an item about having a small discussion group to discover domestic abuse and the role of the Health and Wellbeing Board and the relationship with the Community Safety Board. That hasn't started yet. I'm not sure if did we actually agree that, Alison?
Yes, it was part of I think the discussion in the safeguarding report. So as an initial piece, Robin, Suwan and I were going to have a little conversation around that, and we've got meetings in place with Robin and Suwan in relation to a couple of the items, so we'll pick that.
Okay, thank you. That will be helpful.
Steps.
I mean, I think that probably initiated that discussion in the last meeting, because I did refer to the fact that we might have a report on domestic abuse. Some people didn't think that would be appropriate to bring it here. I think the only reason I raised that was not so much that we necessarily expect a report from the police, but as sadly they are one of the organisations that never attend, they're never here to actually just pass comments on those, if they'd have been in the room, they could have just given us a 1 minute commentary on that particular issue. Now, we all understand probably why the police aren't in the room, because actually the people of Derby expect professionals who are paid to actually deliver on the day job. And that's what we all expect, actually, and all the councillors expect that of everyone in the room and services such as the police. So if they're not here, I'm sure that is for absolutely valid reasons, and we understand that. It's just that as they're not here, if they're not going to be members, we can then decide that if we are interested in that as a topic and it fits in with our concerns as a Health and Wellbeing Board, we can nevertheless invite them, whether they're members or not, to give us an update. So I think that's what we probably will do, Alison. Thank you. Then to consider the role and function of the joint strategic needs assessment, data sharing role, etc. So you've got a meeting line for that. So one point I will dwell on for a second, don't worry Chris, we are getting through this, is the fact that we did look at, say, we would review the child poverty figures. If you remember, they seem quite shocking, even though we know child poverty is high and rising. And we'd look at that. I have looked at that, Suan, obtained the details for me. I'm confident that those figures are consistent. There hasn't been a change in the way those figures are collected. They are, to the extent that we accept the modelling for defining poverty, then those figures are valid, and obviously that makes them a real issue for concern. I have also now, as a consequence of that, looked at the draft anti-poverty strategy, and that is going to be, that's been out for comments. I have made a few comments in my capacity as a chair here. I fed them through to Heather Green, and I must say, I feel it's a very impressive document. It focused on very much on what we can actually do as a system here in Derby. So we look forward to seeing that being published, and we will have actions for this partners here and for everybody in the city, and hopefully we can discuss that when it is published. So that's all complete. We haven't done this. There was a request to report back to the Safeguarding Partnership on actions, and that's a bit soon, isn't it, Alison?
No, discussing that with Suwan in terms of how we do that.
Okay,
so
thank you. We were a bit shocked. We were asked for a complete response at this meeting. Well, that's a bit too short timescales for the way this kind of operation usually works, but we'll get on top of that. Thank you. Query has been sent to the regional team about vitamin D. That's in progress. Councillor Kerr, so that will be okay. Update and work in relation to infant mortality. We look forward to that. Thank you. and that's in progress, and to liaise with communication and colleagues to consider increasing awareness of the NHS app. That was a good recommendation, and you say that's in progress, Alison. So very quickly, sorry, I did feel it's important to run through the action log if we've got one. Do we have any comments on that from anyone? Thank you very much for that then. Thank you for bearing with us on that. So most of that is in progress apart from the issue around domestic abuse, which I think is perhaps a misunderstanding anyway in the meeting. Okay, so now then we're going to move on to our first item. Chris, I like to say Weiner, Chris, because it's German really, isn't it? But it is Weiner, I suppose, is it? Anyway, Chris Weiner or Weiner is going to present an item to us on, he's going to give us a brief update on delivery of NHS immunisation programmes in the city. Thank you.
Okay, thank you, Chair. So, yes, I tend to use Weiner rather than Weiner, but that's just a reflection of my family background, I think there's. So, thank you for asking me to come along and talk to you about immunisation. There is a presentation, but I don't want to go through that today. I'm happy for it to be shared offline. I think it's important that I'll just give some introductory remarks and then open it up to questions and conversation, if that's okay, Chair. So, the first thing I want to say, actually, is that if you ask yourself the question, what single intervention has delivered the most benefit in terms of improving health life expectancy and for people right around the world, then immunisation is probably the #1 intervention. You know, through immunisation, we've managed to eradicate some horrendous diseases from the face of the world. Diseases like smallpox and things like polio are incredibly rare now, and I think have been removed from a substantial number of continents across the world at this point in time. And the good news is that actually within the UK, we've got some of the best immunisation services and programmes anywhere in the world. Okay, but that's not to say we're in a perfect position. Okay, our immunisation programmes deliver to young children, delivering things like the MMR immunisation, mumps, measles, rubella immunisation. Okay, it also delivers to teenage children, where we have various booster programmes, and also things like the HPV immunisation, which is important in terms of trying to prevent things like cervical cancer in the long term. We have an immunisation programme which is delivered around pregnancy, with focuses on things like flu immunisation in pregnant women, and also whooping cough. And then we've got the immunisation programmes for those with long-term conditions and those in the more elderly groups within our community, with a big focus on things like a very, very strong position in this country. However, we've still got work to do. The ideal position is that we deliver herd immunity for our immunisation programmes. What does that mean? It means that if you get an isolated case of something like measles, that it doesn't spread further in the community. It doesn't stop it altogether, but it stops the onward spread of those conditions. For something like measles, you need around about 95% coverage within the community to prevent that onward spread. We're not there consistently, and therefore we do see clusters of disease around things like that going forward. At the other end of the sort of age extreme, herd immunity around things like flu immunisation is probably never going to be delivered. However, we know it is of huge importance in terms of actually protecting our more vulnerable members of the community from admission to hospital, complications of things like flu, and death, ultimately. These are very, very serious infections, some of these things that which we are immunising against. Personally, I'm a huge advocate of immunisation programmes. I have no qualms whatsoever in recommending immunisation either within the childhood arena or the more elderly population. I strongly encourage families, my family members, you know, to get their flu every year, to get their COVID immunisation every year. When I have friends who are having young children around me, I strongly encourage them to get their children immunised against all of the childhood infections. Huge importance. We're in a strong position in this country, but we've got more work to do, Chair, and I'm happy to open it up to conversation.
Thank you, Chris. So I'll take comments and questions. I'll just ask you to keep your comments and questions brief because Chris has to leave at 1:25. So first of all, Councillor Heselgrave.
Thanks very much, Chris, and I fully agree with you about the immense impact immunisation has had on the health of the world's population, and it's a great advancement for us. I just want to pick up on page 15 and 16 on the adolescent programmes for various injections and the performance in terms of uptake, which is low, and it's lower than the national average, and 59.2% is not a figure I'm sure you're happy with at all. I share that, and I wonder what strategies we have. Is there an issue of parental diffidence about getting injections? Because I know that could be a social media phenomenon about certain things. It was against the vaccine during COVID, wasn't it, for a segment of the population? And it also applies for, on page 16, the general performance on the meningitis ACWY immunisation programme. Any comments on that, and what strategies have we to increase the uptake?
Thank you, Councillor, for the interest. So, I think there are two things here which are at play. So, first of all, I think we're almost a bit of a victim of our success in immunisation programmes. For many of these conditions, people forget how serious they are because actually we don't see them that often because we've got good immunisation programmes in place. So that's the first thing I'd say. The second thing I'd say is actually, look, I recognise, acknowledge there is mistrust of some of our immunisation programmes, often related to strong cultural histories that influence the way people think, and also because of misinformation, which is circulating in environments such as social media, as you say. So at the moment, we are expecting the full responsibility for immunisation programmes to transfer back to local NHS structures in 26-27. And one of the key things which I'll be working on when that happens is the strategy to engage with local communities, to continue with the positive promotion of the immunisation programmes, get the engagement in those programmes, and help to address some of this misinformation which is out there and build that sense of confidence that we need for these programmes to continue to deliver with high immunisation coverage going forward. But I think, as I say, it's a complicated space, but we can do a lot more about it. So some people may remember that it's about 20 odd years ago now, we had some initial scares around MMR immunisation. Immunisation coverage dropped considerably for a period of time. I was charged with trying to get that back up in the area in which I was working, and we got that immunisation programme back up to coverage of 95% plus that herd level of immunity. So that it does require lots of local work, confidence building, tackling that misinformation, and if you do that, you can recover the positions. But does that answer your question, Councillor?
Thank you, Ken. I'm just going to move on, if that's all right. I get that because they've got a couple of people who want to come in, if that's all right, Paul. Thank you. Councillor Khan, and is it Andaley, is it from the Derby, University of Derby?
Yes,
Okay.
it is.
Okay, I'm going to take Councillor Kerr first then, thanks, and then I'll bring you in.
Thank you, and thanks for what you've just said, because it answers quite a lot of the points that I wanted to raise in terms of the misinformation and where people get their information from. What remains is a suggestion which I think is the society's memory of how nasty some of these diseases are has really faded. Some of them I didn't know as a child, and it was my mother who knew about it because her parents were doctors and they saw them. So positioning that as part of history within schools, I think might educate people in a way that is non-judgmental but important. And I don't know how you do that, but it may be that talking with the council about that would be a way of doing that, or maybe there are other directions that we need to be doing countrywide in terms of curricula. One of the things that for me, I don't know what's happening at the moment, is one, what impact it's going to have with some of the statements that are coming out of the US at the moment from Trump and the like, and whether they're going to impact on Britain and make it more challenging for us to safeguard the health of our society. And the other thing that is my ignorance is that we know some immunisations give you virtually lifelong protection, and others are relatively short-term. And I think that is an area of understanding that needs more explanation to the general public, because I'm sure I'm not the only one who is confused by, why do I have to have this every year?
Okay, is that the question? Thank you, Councillor Kerr. I'm really sorry to cut you off there, but I think I'm really conscious of that Chris has got to go on to a national meeting. So I thank you. I think that you've asked your question. Thank you, Chris. Have you got time to brief?
Just to briefly respond to that, I completely agree with the fact that people are unaware about how serious some of these conditions are these days. Very, very important that we try and allow people into the space where they can remember that, or at least acknowledge that. Yes, there's a lot of misinformation flowing around the world around immunisations. I don't know what the full impact will be of some of the stuff which is being said outside of this country, but I can guarantee you that we will be working to minimise the impact of any misinformation, either in the country or outside, going forward.
Thank you, Chris. Have you got 1 minute, just to, because I'm aware that, is it Anderley, sorry, would you like to come in from the University of Derby?
Thank you very much. Chris has addressed the question that I had. It was around what strategy do we have in place to address those areas where we have lower than we need immunization. Okay,
thank you. So that's basically, I think we need to let you go, Chris. Is that correct? Have you got 1 minute? Did you want to come in, Amjad, on this? Have you got 1 minute? Do you need to go immediately? Have you got 1 minute?
I've got a couple of minutes.
Okay, thank you, Chris. Amjad.
Thank you, Alison. It was more of a comment and an ask. Recently, we've seen the ICB reach out to the voluntary sector in terms of helping building that trust, rolling out programs. And when it comes to building trust, it's the voluntary sector that the integral part of that piece, especially when it comes to communities. And the ask is, rather than these pieces being ad hoc, it's be embedded within the design and implementation of any future policies when it comes to immunisation programmes across the city, in particular areas where the system finds it hard to engage.
So if I could just acknowledge actually the importance of the voluntary sector. I fully recognise it. We need to meet communities on their patches and recognise the needs, the cultural differences that we have on a local footprint, and actually the voluntary sector is hugely important to us in being able to do that successfully. I imagine we will be doing a lot more work with you going forward.
All right, thank you. Sorry that is a little bit rushed, but Chris does have to go now for an important national meeting which has been called for this afternoon. Unfortunately, Wes Streeting didn't check whether we've got a health and wellbeing board. It's a bit inconsiderate of him, but he didn't, so we're carrying on anyway. So thank you, Chris. Thank you for that, and we look forward to some positive outcomes from this afternoon's meetings. Thank you. And so now we're going to, we can talk about immunisation again if people feel we've had to skirt over that a little bit too quickly. But I'm pleased to say that now we have item number 6, which is an update on the Derby and Derbyshire Childhood Obesity Plan from our public health colleagues Lisa Byrne and Andy White. Thank you.
Hi everybody, yes, I'm Andy White, I'm Public Health Manager, so I'm the lead for childhood obesity over Derby and Derbyshire.
Hi, I'm Lisa Byrne, Consultant Public Health.
Next slide, please. Yeah, so I'm just here to give you an update on our childhood obesity plan. I know I've been to the board quite a few times before to present what the strategy looks like, what the plan looks like, and the progress we've made both across Derby and Derbyshire. So we have the childhood obesity plan time for action across both Derby and Derbyshire, and there are two main objectives within that plan. One is to identify children already overweight and obese and to make sure that they've got access to joined up long-term support. So they're the children's weight management pathways. The second one is around implementing a whole systems approach to help children maintain a healthy weight with the hope that this will reduce prevalence of overweight and obesity over the next 10 years. So that's the childhood obesity plan. Just to give a bit of background in terms of what the principles are behind the childhood obesity plan. So we implement a systems leadership approach, and that's an acknowledgement that it's a shared responsibility of all partners. We all have a contribution to make to reduce the impact of obesity on society, and it's that non-medicalised approach. The narrative we're trying to create is around an understanding that it's less about choices and lifestyle and more about options and empowerment. So it's taking that blame away from families and individuals and looking more as a system around the obesogenic environment and what impact we can make at that system level rather than that historic eat more healthy and be more physically active. So they're the kind of principles that are embedded behind it. My next slide.
Just stop you for a second there, Andy. Do we have no? Do we have no signal at all on this?
I can get it back. It's just taking its time getting through. I do apologise.
That's all right.
I'm so sorry.
No, I've just got a bit of a story actually, so that the slides don't necessarily make
Are you able to continue?
Yeah, of course. So I wanted to, while I'm creating a narrative, I also try and use a bit of storytelling behind it because it brings it to life just to highlight the challenges that a child and a family are experiencing as part of that system that's not conducive to a healthy lifestyle or living a healthy lifestyle. So starts in the early years within the home environment, and this is a hypothetical situation. And this is a hypothetical name of Zach, and his journey begins within the home. So the pantry is stocked with processed snacks, sugary drinks and convenience foods. Zach's parents don't prioritise the preparation of healthy home-cooked meals as they struggle with the time and skills to prepare meals from scratch. Screen time is the primary form of leisure and physical activity is minimal, as both parents are busy working long hours in low-paid jobs, which leads to fewer opportunities for family walks and outdoor playtime. I think we're on slide 4, if that's okay. Yeah, that's it. I'm more it's all right, I'm more of a visual learner. So yeah, I'm going to take this. So I've been through the early years. The school years, so the primary school has academy status and has a freedom to access cheaper, less healthy food supply chains. So school meals are high in saturated fats and the drinks served are high in sugar. Neither food or drinks meet school food standards. So the emphasis within the senior leadership team is on academic achievement rather than physical activity and high quality food served in schools. So Zach's therefore less likely to engage in structured physical activity during his school day and is now starting to develop a real lack of interest in sport and physical activity. His after-school activities are now habitually sedentary, like watching TV or playing video games with friends online. So stage 3, in terms of that community element, the lack of resources within his local neighbourhood and where he lives, like safe parks, walking paths and recreational facilities, the traffic congestion or perceived lack of safety discourage outdoor play for Zach. so spends more time indoors, and because his local environment doesn't offer stimulating outdoor activities. In terms of the access to healthy foods for Zach, the local store doesn't offer a wide variety of fresh produce, and what they do offer is more expensive. Fast food takeaways and fast food chains are more accessible, offering quick, calorie-dense foods, often cheaper and more convenient than healthy foods. And then you move on to that influence from media and technology. Whilst viewing social media platforms, Zach's bombarded with advertisements for unhealthy foods through fast food delivery apps and clever marketing tactics. These advertisements are often targeted towards children, making them more likely to crave unhealthy foods. This, together with social pressures from friends, are starting to normalise behaviours like eating junk food and even a visit to a local youth club. The snacks provided include chips and sugary treats are often shared, which means the consumption of unhealthy foods are now both within the home and community environment, the social settings. As a result, the health consequences mean that there are weight gain and health issues, and as Zach gets a bit older, he's starting to gain weight due to this combination of poor eating habits, lack of physical activity and those social influences. He gets to year 6, so age 11, and is now starting to live with severe obesity. He starts to experience early signs of health problems like high blood pressure, high cholesterol, and is pre-diabetic. And that there's emotional and physiological impact as well as psychological impact as Zach starts to get bullied at school, which then results in his negative body image resulting as a result of his weight gain. So this in turn starts to affect his self-esteem, and emotional eating starts to exacerbate this cycle, and food becomes a source of comfort. As Zach gets into his teen years and adolescence, the effects of the obesogenic environment become more pronounced, and at this stage, as a teenager, he starts to feel the pressure to conform to societal ideals of body image, but he now struggles with adopting healthier behaviours, especially after not having positive role models or access to support to enable this change. So in terms of reflection on Zach's journey through this obesogenic environment, it's a cycle where surrounding influences, family habits, school environments, community access and media just reinforce unhealthy behaviour. The lack of healthy food options, limited physical activity opportunities and environmental stresses contribute to a higher risk of obesity. Breaking this cycle requires a whole systems approach at multiple levels, including better access to healthier and more affordable foods, physical activity opportunities, access to green spaces, and fostering healthy family dynamics throughout the life course. It just highlights kind of how society or the system is very much against Zach into adulthood. But there's a potential. If systemic changes are made across all the wider determinants, this approach has started in Derby and Derbyshire through our whole systems approach, and this next slide highlights the great work underway. So we've been implementing a whole systems approach as part of our system-wide action on childhood obesity. We're utilising the Public Health England or OHID whole systems approach toolkit for local authorities, and we've been working through this over the last 5 years, and we're now in phase 4, which is action planning. So I think there's just an acknowledgement to the board that we are following the evidence base that is out there and the local authority whole systems approach. And next slide, please. So as part of our action planning, we held a Children's Healthy Weight Summit in the summer. This is a group of interested stakeholders coming together and doing some action planning around what actions are currently underway throughout the system and what more we can do. There's a rather complicated Excel that sits behind this because, as you can imagine, we had 100 stakeholders at this event in the summer, and we all kind of documented who's doing what where as part of our whole systems approach. But this just brings out some of the more relevant ones as that kind of helicopter view. So you can see the activity within each part of the system as part of our whole systems approach. So those which aren't highlighted are those which are kind of cross-system, so they're Derby and Derbyshire. The ones highlighted in yellow are Derbyshire-specific, and those in green are city-specific. So I think it's just give kind of colleagues a real good overview of who's doing what where, and an acknowledgement that there is activity within each part of the system. Now, there are gaps within this, and we've acknowledged those within our whole systems approach, and throughout phase 5, which is through this year, we're going to be looking at utilising these gaps. So next slide, please. Part of that is our local authority healthy weight declaration. I know Councillor Martin's been a big advocate of our healthy weight declaration. So this is the City Council signing up to take considerable action on healthy weight as part of the 16 commitments. So these 16 commitments are under the headings strategic or systems leadership, those commercial determinants of health, so advertising and planning, health promoting infrastructures, organisational change and that cultural shift. So the emphasis on the healthy weight declaration is very much around that strategic leadership, creates an opportunity for senior officers and politicians to affirm their commitment to an issue, as you can see from the photo, some elected members and some wide key stakeholders as part of this declaration event that we had in May this year. It also helps shine a light on the importance of key activities both internally and externally. I think the importance of the healthy weight declaration is an acknowledgement that we're looking internally at some of our policies and processes within the City Council, but also it ties really well into our external activities as part of our whole systems approach. But it's also a tool for staff to use to create opportunities for healthier places to live and to work. So it's very much that conversation start across departments, and Councillor Martin's been kind of pivotal in creating those conversations for me within those different departments. Next slide, please. So the next steps, we are having conversations, I think I mentioned earlier, around the acknowledgement that we want to take that blame away from families and individuals and look more as a system about what we can do. We have identified the building blocks for better health as a framework to support this, a communication tool that we can all use as system partners to help have a consistent approach to looking more of a system rather than individual and family blame. So we'd like to use building blocks to better health as that framework, and we're advocating support to do that, but also we want to continue the journey through the 16 commitments within the Healthy Weight Declaration with a particular focus around those commercial determinants of health. Next slide. Hand over to Lisa.
Thank you. So it's really clear there's loads and loads of really good work going on across all of this whole system stuff, and there's been a lot of work as well on the pathways and the services for children who already are overweight and obese about how we support them. It's fair to say that despite lots of progress, we still do have some quite significant ongoing challenges. So we've made a lot of progress, but lives are still being cut short by obesity, and that is the reality that we're in at the moment. Moderate to extreme obesity can shorten life expectancy by 3 to 10 years. Some estimates suggest even more. So given that the burden of obesity falls disproportionately on our least affluent communities, it's a huge driver for our poorer communities dying younger. So despite all of our efforts, and notwithstanding a big drop from a big peak during COVID, the trends show that childhood obesity rates are not falling. They're mostly static in reception age children, but trending upwards among Year 6 children, nationally and locally. And our local National Child Measurement Programme data from 23-24 shows that about 550 children in Derbyshire and 206 children in the city specifically are living with severe obesity. So many of those children report being stigmatised due to their weight. Those impacts, like Andy's described in our story, can include bullying, increased risk of depression, anxiety, social isolation. So this isn't just about the physical consequences of excess weight, it's about the social and psychological consequences as well. That can in turn result in poor educational outcomes and poor employment prospects. So this is really something that we need to address for the health and well-being and broader well-being of the residents of Derby. We know that children living with obesity are at increased risk of ill health into adulthood as well, so this isn't just about children, this is about the health of our future adults. And it's estimated that the NHS spends £6.5 billion annually nationally on treating obesity-related ill health. So there's also a big driver financially for our system across health and social care to support this work. So we really can't afford not to tackle childhood obesity. So just going back to what we achieved so far and away from the doom and gloom for a moment, if we go to the next slide, thank you. We have got improved access, experience and outcomes as part of this new improved child weight management pathway across Derby and Derbyshire. You can see up there, some of those are county specific but are still relevant for the city in terms of learning. There's been a lot of progress around the development and implementation of Tier 2 children's weight management offer. Increased capacity in particular for our service here in Derby City that's delivered by Derby County Community Trust. That now has the capacity to see 300 children per year, and that contract's been extended. We've implemented a 0 to 4 partnership pathway in Derby City, which is really strong. So partners involved in that pathway include Derbyshire Healthcare, NHS Foundation Trust, the Family Hubs, and Derby County Community Trust. So it really is a big partnership effort, a lot of this work. And we're improving the partnership pathways through primary care as well in Derby City. So that involves proactive follow-up calls to parents after receiving their National Child Measurement Programme letters and reception in Year 6, and practitioners making the follow-up deliver a brief intervention and signposting to services. And there are links here with safeguarding as well, so where parents don't engage, checking whether there are any safeguarding issues around neglect that might be associated with very severe obesity. There's also the implementation of a pilot pathway through Chesterfield Royal Paediatrics team with First Steps. So that is focused on the north of the county, but there's learning there from that pilot that we're looking at what we can do in the city and our pathway across the system as a whole for the children who are very severely obese and what support they might need. And then at the centre of all of this, there's a pathways document that's been developed with Andy leading on that, which details all of those services available across the system. So the next step is to make that more easily accessible to people so that families can see it as well as professionals and make sure that people can get the right help at the right time. Go to the next slide, please. So our current pathway challenges, there are still some that remain. These are those main 3 that are identified as risks in the Children and People's Delivery Board risk register. These issues are resulting in the needs of some of our most clinically vulnerable children still being unmet, but we have recently agreed with the Children and Young People's Delivery Board that the Strategic Children's Healthy Weight Steering Group will develop a business case that addresses these risks and then report back to that delivery board for further discussion and escalation. And that will tie in quite nicely with some other national work around funding for complications of excess weight clinics for children, which will be coming to ICBs from 2026, and also with some work going on around adult obesity and the adult obesity sprint. So we're hoping to pull lots of these different things together and make sure that our support for people with excess weight and obesity is all aligned. So support we need from the Health and Wellbeing Board. You can just skip through, Lindsay. Thank you. 3 things. Firstly, just to acknowledge the progress that has been made around those 2 objectives of the Derby and Derbyshire Childhood Obesity Plan over the last few years. There really has been quite significant progress. Highlighting those further partnership opportunities to support further progress of our whole systems approach. So as Andy's described, that really is something that everybody needs to buy into and take responsibility for. And there's something that we can all do there to support children's healthy weight through that whole systems approach. And finally, to provide support and leadership in the future development of framing and using the building blocks and how we talk about children's healthy weight and how we try to turn some of that narrative so that people understand what's really behind a lot of this and how, yes, eating well and moving more is really important, but we need to provide an environment that enables families to do that as well. Thank you.
Thank you. So if you could just hold that slide as well, thanks. Thank you. So everybody in the room probably knows this is a priority for me and how important I think this is. So because of that, I'll refrain from saying anything at all myself right now, and I'll invite comments and questions from the floor. But thank you very much for the report. So I've got at the back, please. Thank you.
Thank you very much for this presentation. My name is Andile Mabala from University of Derby. Thank you for your presentation. I'm pleased to hear that you are taking a systems approach to obesity. I think that's the best way to do. And I'm just wondering if you've got any examples that you could provide where the interventions at a structural level rather than at individual level. And the second question is if you have got any plans to provide evidence of effectiveness of the approach that you are taking. That is, do you have any way to measure that the measures you put in place are driving down the prevalence of childhood obesity in our patch? Thank you.
Thank you. It's a really good question. And in terms of some of the pathway work, we can see we're getting more children through, and we've got some good outcomes data from the children who are engaged in our Tier 2 services, which is really promising. The challenges around some of the longer term and the whole systems work is that a lot of this is quite long term, and it's not that easy to evaluate in isolation, because it's rarely one thing that's changing at a time. So we're changing lots of things all at the same time, and it's hard to identify which of those is making an impact. Also, we know we've still got issues with childhood obesity rising. We don't know whether that would have been even higher if it weren't for the interventions that are being taken. So it's quite hard to unpick in terms of evaluating effectiveness. What we can do is base it on evidence that is well established and peer reviewed, and so that's what we're going on. And work on the assumption that if that is demonstrating impact from the evidence base, that it will demonstrate an impact within our communities. So there's probably more that we need to do to look at how we can evaluate that locally, but it is quite tricky because it's so hard to unpick one thing at a time when we're not doing one thing at a time.
Thank you. If I may, just very quickly, I think that, one value of this work is just keeping the discourse going, which may sound a bit facile, but just imagine if these children were on the verge of dying, or if they had dramatically reduced life expectancy because they were now malnourished, because they were underfed. We'd think that was a third world problem. We'd be, people would be up in arms over that. It's somehow, it's to do with the psychology of this belief that people are eating too much, and that's I think that's why this kind of changes this, some of the approaches to this. But it is an absolute health crisis, I think, and we do have to keep the discourse going. We can't keep our eye off this because, people are going to die, and they will die early. But I will now shut up and take another comment because I go on about it forever. Councillor Kerr.
Thank you. I feel desperately sad about this whole situation because life shouldn't be like this, and it shouldn't be having to have the real challenges we've got in this area. So, for example, we shouldn't be normalising body shape that is not healthy, but yet we can't be ignorant of the fact that if you feel your body shape is wrong, your mental health issues expand. And I don't know how we balance that as a society or even in the individual things. But the wider engagement of this, I think, is something that we can still be doing a lot more to help with. I'll give you one practical example. A little over Burton Road and the Ring Road currently has roadworks going on for 16 weeks. It is causing havoc for the walking routes to school. So anybody who's wanting to walk from the Normanton area to Littleover Community School now has to do a quarter of a mile diversion to get around the official crossing route. And that is going to discourage people from actually walking to school, and they will be continuing to drive just at the point when we should be getting the message out there to say, walk, because the queues are going to be worse because of the traffic lights. And we're not working within the potential of that system to, A, get the message to the school and get more people walking, and we're not getting a walking route that is actually beneficial to encourage people to walk. And this is an example of a very microcosm of the whole system approach, which if every opportunity was grasped, we might make a difference. I don't know how we get that grasping of every opportunity, but, all power to everyone's elbow.
Thank you. If I could just come in there. So it is an issue, Councillor Kerr. I could talk to you outside the meeting, but very briefly, I think you do raise a really important principle there about roadworks, and I know how busy Burton Road is anyway. You have to get to that crossing to get across unless you're playing chicken or something. So have you contacted, I'm not saying this is your responsibility for whether you've done something or not, but as a matter of interest, have you contacted, highways and people to ask for them?
Yeah, I've had conversations. I've had conversations with the project manager on the scheme and his boss.
Okay. Well, if there were anything I could do to help with that, obviously I'm happy to do so, because it's clearly, I mean, I think you just raised, it is a small detail, it's a momentary thing, but it is the principle, isn't it? Which is that all the time, pedestrians in particular are not always necessarily thought through. I have to say, as a council, I feel we are often doing our best. Certainly the messaging from the Cabinet is very much, you know, pedestrians, active travel, but it's just, obviously, you know, you get a scheme like this and it just it just flies through the window, or whatever the term is. So I think you do raise a valid point about, at all levels, we need to keep on reiterating the importance of allowing kids to walk and walking. Any other comments, Councillor? I'll bring in somebody who isn't a councillor first, if that's all right, and then I'll bring in the councillors. So, Alan, thank you.
Thank you, Chair. In terms of the support for further partnerships, linking into the Derby City Police partnership, where have you done that yet, or have you planned to come along, or can I invite you along to?
I know we did present to the Place Partnership about 2 years ago, but obviously a lot's changed since then, so an invitation would be welcome.
I'll link in with you to
get
come
wider
along
partners
with
on
that
board.
as well. And in terms of the other police partnerships around the county, have you?
Yes, well, I go through the local children's partnerships within the county, so that's my kind of avenue in, because they're more of a kind of children and young people's focus, so they've been my main forums that I've been accessing, but feeding into the place partnerships when they've taken an interest in kind of children and young people and the Children's Healthy Weight agenda.
Yeah, so the Derby's, we're meeting with the leadership team of the Derby City Police Partnership, are meeting next week to discuss our plans for focus for next year. And I know Children's Obesity is in there, so it's a great time to bring you back. So great, thanks.
Before I just bring Councillor Ashby in, as I say, in terms of the council, we did sign the Healthy Weight Declaration, and Andy and I had gone through the points within the Healthy Declaration in some detail. We've got a little bit more work to do. So sometimes work is happening and it's not obvious that something has or hasn't happened, but it is happening, and we are talking to all many departments in the council to cover the prescriptions there, aren't we? So nevertheless, it is really concerned. I mean, that isn't going to stop obesity rising, but the continued rise in obesity is really perturbing. And but anyway, I'll bring in Councillor Ashby.
Sorry. Thank you for your report, which was very helpful to read, but also in equal measures horrifying. And it feels to me, having been in healthcare and general practice, you know, from 30 years ago, this problem has escalated in the past 30 years. In North Derbyshire, we weren't even seeing more than a handful of patients with diabetes under 40 back then. You know, it was a rarity to have somebody under 40 with diabetes now, let alone, you know, the childhood obesity. So I have a few comments. One was, unfortunately, we couldn't read the visuals in Figure 1 and Figure 2, either on the hard copy or on the slides. So next time, if we could have those on a whole page so that we can see them. But that's only a small aside. You talk about a whole system approach, but does pre-birth come into it? Because I really feel, I mean, I think, you know, it's complex, all the reasons. There's so many reasons for childhood obesity, as we all know, and don't need further rehearsing. But when somebody is pregnant, it's a great time to catch them for, you know, education on, you know, because, you know, with your first pregnancy, you know, you're open to education about everything. And are we looking at the prenatal period is one of the questions I would ask. I suppose what would be great to research is whether the lack of health visitor input in those early first 2 or 3 years into, you know, educating parents on what to feed children, let alone activity, must be having an impact, because, you know, the children are arriving at school obese. You know, is it 1 in 4 children arrive in reception obese? So those early years I'm really concerned about. And the other question I have is, again, having worked in general practice and seen children who are obese, spoken to parents about overweight children under 5, there's actually nowhere to refer them. So do you now have pathways, or are you developing pathways for general practice to, streamline some approach to give support and education at that stage? Thank you.
Should we work backwards on these, and then I'll come to Andy for some of them. So in terms of the referral route for GPs, that pathways work that we were talking about and having a single place where we can keep all of that information has been a really big part of the work of the last few years. So that's what Andy's been trying to pull together. The kind of final step of that is making sure that it's somewhere that's accessible. So that is work that's in progress. Andy's identified a place where it can go on the Joined Up Care Derbyshire website. There's just some work going on to make sure it's accessible to people and is easily readable and
So
fits in terms of health literacy.
Rather than hands-on input?
Yeah, in terms of the pathways bit, but in terms of that link with the GPs, to make sure the GPs have got that link in with pathways, yeah. In terms of early years, I'll come to Andy on the early years bit. On the pre-birth bit, there's quite a bit of work going on around preconception at the moment and having a healthy pregnancy and also being healthy in preparation for pregnancy, given that we know a lot of pregnancies are unplanned. So there's a lot of work going on in that space. The local maternity and neonatal system funded some work that the county are leading across the whole system on a toolkit for professionals, but also that will also be a public-facing campaign for women of childbearing age around getting healthy, staying healthy and having a healthy pregnancy. So that work is underway. It also links with some work that we brought to the last Health and Wellbeing Board around infant mortality, because we know that maternal overweight and obesity is a factor for infant mortality. So there are lots of things at the moment that are kind of all coming together quite nicely at the same time. But completely agree that that preconception work is really important. It also fits with women's health hubs. So we're trying to advocate for more around preconception health through the women's health hubs. Andy, do you want to take the bit on health visitors early years?
Yeah, I mean, as Lisa mentioned, in terms of that 0 to 4 pathway, we've got health visitors on board in terms of developing further interventions from a 2-year review. So if a child's identified as being over the 91st centile at that 2-year review, there's an enhanced pathway for that child. That is a series of extra visits for the family and the child, but also signposting to our 8-week parenting programme as part of our family hub offer. Obviously, within the city, we've been fortunate enough to qualify for national funding from family hubs. They've started to deliver an 8-week programme to support families around education on healthy eating, physical activity, and just some practical support in terms of cook and eat as well. So that's ongoing within the city as part of that kind of collaboration between health visitors, family hubs, very much in line with the family hub ethos around, that partnership working and that kind of single point of access.
Thank you. Is that work specifically geared at people who are children and families who are already obese, or is that geared at all children? And in terms of the antenatal input, I was also meaning input in terms of education for parents about what to do, because if they've come to, if they've got to 2 and they're already over the 91st centile, they've already been getting into bad eating habits, sadly, and the parents are already in habits of feeding children badly. They've been on solids from 6 months, so they've had 18 months of going down a very bad track.
I think that's where our whole systems approach comes in terms of, advocating that it's everybody's responsibility and utilising the partnerships we've got. I mean, Lovewell, the service in the city, have got a pre- and postnatal advisor. So she will support mums, not necessarily identified as being overweight during pregnancy, but also universally. So she does many universal programmes. So an aquanatal session over at Moorways, for instance, and that's universally accessed. I think the challenge we've got is around communicating that these services are out there. So yeah, I think that's about as much as I can add on that. Just in terms of the universal approach within health visiting. Obviously, the Healthy Child programme is universal. That's every child is weighed and measured at 16 weeks and at 2 years. So as part of that, if a child is identified as being overweight or obese or on a steeper trajectory in terms of obesity, that is when the 0 to 4 pathway will kick in. So the actual screening is universal through the Healthy Child programme, but the intervention is very much targeted towards those who are on a kind of steeper trajectory.
Thank you. I am slightly mindful of time. Obviously, we've got. I mean, all within this board, we always have some really compelling topics to discuss, and the next one is equally compelling. But I'm just going to take few more questions, if that's okay. And then I'm aware that we do need to move on, but I'd remind the board that the ask here is to, think about what partners can do to provide the support and leadership in this work. Think about partner opportunities. I mean, it exists everywhere. This does every time. Every time you have a small reception for people, put on a bit of food. What kind of food do you put on? I mean, it literally is at all levels. This, so it's a really important topic, as you know. I think that. But I'm going to bring it. So I've got Councillor Hazelgrave, and then I've got Amjad, and then I've got Margaret. So if you could keep the comments, fairly brief, thank you.
I'll be as brief as I can. I'll be as brief as I can be, Chair. Some good news, I think, in the school nurse survey, which took place last year. Year 9 pupils, so a big cohort of pupils around the city of that age. A really good indicator was that a lot of them were saying they were taking steps to look at their weight, their health weight. So that's one way you can track, because that's an annual survey. Clearly it happened on one day, and they might have changed their mind, or there might have been a lot of resolve to it, but that's a good indicator, I think. I think also 800 plus people attended the Family Hubs event at the Museum of Making on Monday this week. I couldn't make it, unfortunately. And that's a real indication of what's happening in the early years, where it's really vital that the right kind of dietary habits are formed. Yeah. And 110 people signed up to the library service, which is also a great result, not connected with healthy weight, because if they're sitting reading all day, they should be out and doing stuff. Yeah. Now, the other thing I'd like to say as well is the whole issue of, and I'm looking at the horizon here, primary breakfast rollout, free primary breakfast rollout, in over a year, I think, just about a year from now. Are we looking at the quality of the offer that will come out, and are we aware, are our schools aware of the Food for Life award that's mentioned that Derbyshire Catering has? Because I think that's something we could look at, trying to make sure the quality is uniform across the city. And to add to that, there will be a free element, but lots and lots of schools have ad hoc arrangements and fairly long-term arrangements with various partners, food for thought, etc. I hope those links won't stop because of free breakfast offer, and that we could then supplement the quality, yeah, get maybe more protein in rather than just carbs, right, to make a really good start for children's day in the school. So look, how do we make sure that happens and we keep that quality and raise the quality? And finally, it's not just about diet, it's about exercise. I have some hopes that the curriculum review will actually add more physical activity, and that's particularly important at primary level because it's a sedentary education. They sit in the same classroom, the only time they move is for break and lunch, whereas in secondary school, and I was in one this morning, the young people are walking up and down from one end of the school to the other between lessons, so there is that physical activity. So I hope there's some extra work done on tackling it from the other side, which is the physical activity, which is good for mental health as well. The whole thing is really good for mental health.
Yeah, I can come quickly about Derbyshire Catering. So although it's Derbyshire County Council catering, it also covers the city. So that offer is available for schools within the city, and 9 schools within Derby City currently take that offer. So they automatically are assured that that food meets school food standards, and that's quality assured through Derbyshire Catering. In fact, we only had a meeting this morning, and another two schools are coming on board with Derbyshire Catering. So we're going to be the big advocates for Derbyshire Catering to ensure more schools take that offer up. In terms of school breakfasts, there are 10 schools within the city who are participating in the early adopters. So I've got a close eye on that, and obviously that quality assurance mechanism needs to be incorporated into those school breakfasts as well. Unfortunately, it's around funding in terms of who's the best organisation to quality assure those, and who's going to be responsible for that, because even with school meals, there's no real quality assurance mechanism in there that we can be assured that they are offering a healthy cooked meal through the school provision. We can through Derbyshire Catering, because they adhere to school food standards, through the Food for Life Award, but for any alternative providers, that's a massive challenge and something that we've identified for our whole systems approach.
Thank you. So I think, Sharon, do you want to come in and respond specifically to Paul's point? So what I'm going to do is I'm going to let Sharon come in and respond, because I thought she might want to talk about this very specific point. Then I'm going to take Amjad, and then Margaret, and then I'm going to have to move on, unfortunately. So, Sharon.
Okay, thank you, Chair. So with regards to breakfast clubs, currently there are 69 breakfast clubs operating within local schools. Included within that is 4 secondaries. The cost currently ranges from 20p per session to £10.50 per session, depending upon which organisation is providing that. Obviously, with the test and pilot of the breakfast club programme, we will be working closely, my early years team will be working very closely with those schools as they're already overseeing the extended duties around wraparound as well. So we expect there to be some significant changes in policy about how the two programmes merge over the next period of time, which means we do have to think about how partners are engaged in that conversation, absolutely. We're also in discussion with the City Partnership about how we might address preschool provision, particularly those where in our most deprived wards, where access to breakfast for preschool children isn't part of the current programme and available. So it's one to watch, but we're very keen to make sure that we stretch out as we possibly can, but also the quality of food provided is of good quality, with a possible pilot of looking at family breakfast in some of those areas.
Thank you. And just very quickly, I think it's really important that the food in those breakfast clubs is good quality food, because first of all, I mean, it has to be something that children will eat. We have to acknowledge that, because first of all, you know, that's for those children who may not otherwise have been getting breakfast. It's an important part of the meal of the day. But then, you know, perhaps more worryingly, if they become normative and all children expected to go to school, those clubs, there might be some children who would otherwise have eaten well with their parents who are going into school and not eating such good quality food. So it is, and I know that Andy and Paul and yourself are very concerned with this. So we'll look forward to hearing something more about that. Thank you for that, Amjad.
Thank you, Andy, for the report. Mine's was a quick question and then an offer as well. So the question was more around, appreciate this data is citywide. Is the data pointing towards any certain area or wards that's got higher prevalence of obesity? And then the offer is mainly from the voluntary sector, that we know in certain communities, behaviour change and is an integral part of that whole system's approach and for it to be successful. And for behaviour change, again, grassroots organisations, faith institutes play a significant role in that, especially in communities where you have a lack of engagement, lack of trust with the system and wider system partners. So the offer is the voluntary sector can help with that. We've got warm hub providers. We've also got the Children and Young People's Network, which I know you're connected in with Helen. But then we've got a lot more out in communities, especially grassroots organisations. And if we can increase the skills, knowledge and confidence to be able to address childhood obesity in them, I think that would have a significant impact on this work.
Thank you. Welcome, Amjad, in terms of that invite into kind of more of a community level. I mean, at the minute, the last 3 years, we've been focused at that kind of system level, but I'm really keen to look at a kind of hyper-local level to see what we can do locally. I know as part of the whole systems action plan, we've been invited to kind of formulate childhood obesity or embed childhood obesity within some of the neighbourhood pilots. So we're starting to get involved in locality too as part of that developing neighbourhood plan. So the idea is to look at that at a kind of hyper-local level. Just to back to your point in terms of our data, we only have access to data at that reception in Year 6 as part of the National Child Measurement Programme, but that data does suggest that Year 6 Normanton is the highest rates of childhood obesity in the area, and I know I can send you the breakdown in terms of how that looks from a data perspective.
And yet, Andy, if I may, when we actually look at the stats I've seen in relation to ethnicity, suggest that Asian communities have overall, Asian people have lower levels of obesity than other groups.
I also have the data broken down into ethnicity. I think you raised a similar point last time, and I sent some data, so I can send you some updated data on that if you like.
We have quite a lot of data, so and it's all very interesting. But it's all really interesting. I'm going to take Margaret, and then I have to move on because we're running over a bit. Thank you, Margaret.
Thank you. A few points. First of all, what a fantastic presentation, all the work that's going on, and what great interventions from people around the room. I just got a couple of points. One, in support of Councillor Ashby and the health visitor point. As the NHS tries to move towards prevention and towards neighbourhoods away from curing and acutes, then I think a health visitor in neighbourhoods will be really, really important, because a check at 16 weeks is before you're on solids, and 2 years, as you say, you've got 18 months bad habits. And those of us who are in the room are a little bit older will remember when health visitors were a real part of the community and ran clinics and, you know, health, lots of stuff just going on. And a lot of that has declined. So, I mean, that's something I'll be feeding back into the ICB. The second is the school meals point. Absolutely brilliant to hear what you're doing. But I know a lot of school meals are still on plastic trays and are not very healthy. So the more, you know, it's like keep on doing it and more, isn't it? And on that, the breakfast thing, again, I've heard of some schools saying, but we can't afford to do what we'd like to do, a healthy breakfast. So it's one of these breakfast cereal snack bars, you know, which is not ideal. Food banks struggle to take fresh vegetables and fruit. Food pantries much more effective in that. So again, this is a VCSE point, isn't it? People like Feeding Britain will concentrate on food pantries rather than food banks, where people are able to buy fresh food, etc. So the more we can encourage food pantries rather than food banks, I think. And then I think there's a balance, particularly at adolescents, between eating disorders, which are also on the rise, and inappropriate use of weight loss drugs that you can buy online. And I think that is quite a concern in some secondary schools. So it's balancing, isn't it? Of course, you don't want obesity, but as Councillor Kerr said, if people have got a worry about their body image and they think the best thing to do would be go online and get some drugs which obviously are unregulated, and it's a bit of a jungle out there. So those are my thoughts, and as I said, one thing to feed back to the ICB around the prevention of the neighbourhood, about thinking particularly about health visitors. Thank you.
Thank you, Margaret. I think you made some really excellent points there, and thank you for feeding back to the ICB. Just as an aside, I have spoken with one of the ICB senior people about the idea of the NHS taking, because there is an NHS healthy weight declaration, which I know is not simple to work through in the NHS, because especially through the ICB, it's a matter of trust, but it might be quite, you know, it'd be nice to see locally if the NHS would also do that, which doesn't necessarily relate just to children's weight, but obviously, you know, we've done it at the council. It'd be nice to see the NHS there. But you do make some excellent points, thank you. And the other last point I'm going to make, and then I'm going to move on, is that I think that, you know, a key element of this is definitely the food system and the food we eat. And I'm pleased to see, which we'll come on to later, that in the proposed new health and wellbeing strategy, food is in there, because it's a really difficult and sensitive subject. All these things are sensitive topics, aren't they? Our own weight, the way we eat, it's kind of matter. It's quite sensitive to every one of us in the room, let's face it. But at the end of the day, as Carmel pointed out, I mean, 30 years ago, we were not seeing this is an absolute epidemic. It's an absolute crisis, and we had to take action, you know, rapidly. And I'm, you know, looking forward to more government initiatives on this. But in the meantime, I'd like to thank you very much for the presentation. You know that I'm very closely involved with this work, and I think it's very important. But I'm pleased that everybody has responded to this. And unless there are any other further compelling points on this, I'm going to move on. But thank you very much.
It would be great to have the conversations with the warm hubs about what that provision looked like through the Housing Support Fund moving forward, and also with Youth Alliance and Children and Young People's Network, again, making sure that offer is really solid, and maybe some support for the community voluntary organisations at a very granular position to make sure they understand, you know, we are feeding people because they're hungry, but it also needs to be good food is really important, so we can support with that. And there are over 668 sessions during the winter from those 49 providers.
There's a really excellent point, Kim. I do think there is already some monitoring of the food, quality of food offered by, there should be, as far as I'm aware. You don't think there is, Carmel? This is something we could take this up. Rather than, we are hopelessly over time now. It's entirely my fault. What I'll do would take this up. I know there is some monitoring of the quality of the food that is given out in these programmes, but whether it's good enough. Pardon? Yes, we'll make that as a recommendation, that we will follow that through and ask, and thank you. Thank you. Right, moving on then very quickly. Thank you very much for that. We're now having an update on the work of the DAS, which is the Derby and Derbyshire Drugs and Alcohol Strategic Partnership, called Tackling the Effects of Drugs and Alcohol in this current year, and that's being presented by Richard Martin. Thank you, Richard.
Thank you, Chair. As you pointed out, I'm Assistant Director of Public Health here in Derby City. Robin Jewis, the Director of Public Health, is the Senior Responsible Owner for the Derby and Derbyshire Drug and Alcohol Strategic Partnership, and I'm the Partnership Lead for the county, as well as being a Commissioner for Substance Misuse Services here in the city. That's a lot of gobbledygook, so what I'm going to take you through is what is the DASP, what does it do, how does it translate national strategy into... Have I got the same delights then, Lindsay, that I don't get a presentation? Okay, I'll continue without that then. What I'm going to discuss is the government's drug strategy, because a lot of people won't have that on the tip of their tongue. What is the work of the Combating Drugs Partnership, or the Drug and Alcohol Strategic Partnership? What's it set out to do? I'll highlight some current challenges that we face across the county and in the city, specifically around drugs, alcohol and crime. I'll talk about some priorities that have been agreed as a partnership, and I'll also, if I have time, talk about progress. I'm mindful there's a lot of information in the slides that you're not going to see. There's information in the report that's attached to the abridged version of the report we submitted to government and the covering report. So you're not going to be shy of information. So I'm going to be relatively swift and go through this at pace, if that's all right. I'll recap. What is the National Drug Strategy? There are 4 strands. The first one, as you would imagine, is about crime, reducing drug-related crime, breaking drug supply chains, smashing county lines, and some of these things I'll go into more detail. We're also asked to deliver world-class treatment, drug and alcohol treatment, and reduce the number of deaths related to substance misuse. A key strand is achieving a generational shift in the demand for drugs, so reducing young people becoming drug users and alcohol users or problematic alcohol users in the future, and supporting families. And finally, was largely absent over the last 10 to 15 years is that we were required to create a local accountable partnership at a whole county footprint, and we've chosen Derby City, Derby County, in order to combat the harms caused by drugs and alcohol. So I'll talk for a few slides about our Combating Drugs Partnership, which is called the DASP, who it comprises of, what it does, and hence why I'm here presenting the work of the DASP and other key partners. So next slide, please. This helpful picture describes the Combating Drugs Partnership. It's comprised of key stakeholders, the Police and Crime Commissioner's Office, Probation Service, NHS, the Joint Up Care Derbyshire, and a variety of senior leaders within the local authority, Directors of Public Health, myself, an Assistant Director of Public Health, Directors of Social Care, Commissioners, etc. The vision is that this multi-agency partnership brings together senior decision makers who all have a vested interest in reducing the harms caused by drug and alcohol across the entire county. Our Combating Drugs Partnership, or the DASP, was formed in 2022 and as such has been undertaking a number of activities, and I'll highlight them if I need to, but basically we conduct strategic needs assessments, review the government's requirements, review the nuances of need at a local level, and therefore use that information to inform strategic planning across the domains of crime, drugs, drug harm, treatment, and allegedly prevention for young people. That's something we're going to come on to. Next slide, please. This slide and the following maps outline some of the key challenges that we face across the DASP footprint. There are 5,170 people that we estimate use heroin and crack cocaine problematically. They're two of the most problematic drugs, although there are a range of drugs I'm happy to go into if you so desire, and I can outline the harms and the prevalence that you see of those drugs in the city and the county. Pleasingly, there are 3,900 of those people who use those drugs in treatment across the county footprint, which is quite significant. We're sad to report that when it comes to drug-related deaths or deaths from drug misuse, I don't want to get into the complexities of drug poisoning, drug misuse, and deaths while in treatment, but we are an outlier in the fact that we're 1.5 times higher than the rest of England when it comes to our deaths from drug misuse. And that's largely due to an ageing population of drug users across the city and the county who have a lot of co-occurring ill health, such as COPD, compensated or decompensated liver. So there's a lot of reasons why we seem to be an outlier, and a lot of that is because we've got long-living drug users with a lot of comorbid conditions. Thought I'd choose some rather Daily Mail type statistics to shock us. Every year, or last year, there was 1,885 admissions to Derby's hospitals for the effects of heroin and other harmful drugs. And with an average cost of £3,000 per admission, that's in excess of £5 million that it's costing the NHS for the treatment of drugs, specifically for hospital-related admissions. A similar figure, if we move on to alcohol harm, slightly more expensive to treat somebody who goes into a hospital for alcohol-related harm because they are likely to have significant comorbid conditions. Across the county, we saw 5,000 alcohol-related hospital admissions, and again, that's in excess of £5 million. So this is not small beer, pardon the pun, when we're talking about the economic impact, and that's just an economic impact through the lens of the NHS. If you consider the socio-economic impacts of violence and crime and drug dealing, drug harm, acquisitive crime, you can see that it's costing Derby and Derbyshire a huge amount of money every year in relation to the aspects that we aren't tackling. A few more statistics in relation to alcohol-related harm. Very few people, comparatively, out of the 11,800 that we estimate being dependent on alcohol, or what you would euphemistically call an alcoholic, only 2,500 approximately of those are in treatment. And the reason for that is there's a very different relationship between alcohol and society, and it's a very difficult juxtaposition between alcohol use and consumption and a vibrant nighttime economy and all of that stuff that goes with drinking and problematic drinking. So I think moving forward, I don't think we touch it in this slide set, one of our aspirations is to try and address the relationship between alcohol and society at a local level. Another thing not included here, but Derby City specifically has a density of, I think it is 9.5 licensed premises per square kilometre. And bear in mind, Derby City is 78 square kilometres. We've got 714 licensed premises or outlets. And I'll be speaking to Councillor Martin about this. I can tell you that approximately £849,000 is spent every week on alcohol bought in off-licences and supermarkets. Next slide, please. That map just highlights some of the things I've said. I liked the map, so I thought I'd include it. That breaks out the differentiation between the city and the county in relation to drug-related harm. Next slide, please. This map does the same for, sorry, there were two slides that look very similar. If you want to just go back, yeah, no. Can we, yeah, go backwards maybe? It says, yeah, that's alcohol harm. Yeah, this just breaks out because I'm here in the city and talking about city statistics, the geographies of the county, the issues that we face in the city versus the issues that we face in the county related to alcohol-related hospital admissions, numbers of estimated problematic alcohol users, and some other statistics that help us determine policy. Next slide. We also, as you saw with the earlier drug strategy discussion, the first strand of the drug strategy is to reduce supply of drugs and drug-related crime. These are just some interesting statistics that over that 2-year period, 22 to 24, there were 3,500 cases where people were found in possession during stop and search of illegal drugs, and 2,000 separate cases where people were supplying drugs. So we've got quite a vibrant drug consumption and drug supply market across the county, and quite a high density in the city. For those who don't know what a county line is, the county line is the name given to an organised criminal gang that transports drugs through a county line, so let's say from Nottinghamshire to Derbyshire, or within a county. It's a very popular type of drug supply mechanism that exploits young people and vulnerable people, and is predominantly one of the key or leading types of drug supply. There are numerous county lines operating at any one time. I think currently, at the time of writing this, there were now 9 county lines actively being investigated and operating across Derbyshire. I think I've got a map that also identifies the number of county lines that have been smashed or rolled up over that period of time. For those who do commit crime or drug-related crime specifically and end up either in prison or under a specific order under the purview of probation, 44% of those identified as having a drug need. So out of the 3,500 people who are actually actively on probation books, 44% have identified having a drug need. They use drugs, have used drugs, or need treatment. And 49 identified as having an alcohol-related issue. And a lot of those have been violent as a result of their alcohol use. Next slide. This map just highlights some of the crime aspects I've just described. The county lines operating on our edges and on our borders, so drugs coming in specifically to the city, and the roll-up rate of county lines, and the number of stop searches that have taken place, and the number of supply offences. Next slide, please. And this, again, just breaks down the probation data with regards to the number of people who are currently, or at the time of writing, were on probation, those who have a drug issue or a drug need, those who have an alcohol need. So you can see that drugs and alcohol are fueling quite a lot of problems across the county. So you think, what are we going to do about it? Next slide, please. This slide is more of a summary slide. This says what have we done to date. So we've done a needs assessment to establish the extent of drug and alcohol use and drug and alcohol use related crime across the county over a period of time. So this is some of the work of the DASP in its early days, was establishing the size of the prize, the size of the problem, and reflecting activities that would meet the objectives of the drug strategy. Next slide, please. As a result of that, these, I know they're small, are the priorities that have been established across some key agencies, probation, the police, and public health. You can see that a lot of the priorities relate to reducing the harm caused by drugs, reducing the harm caused by alcohol, increasing access to treatment, making services more appropriate, accessible, and inclusive, recognising the impacts of mental ill health and the use of drugs and how they can exacerbate each other, increasing capacity, increasing the bridge between prison and prison leavers and those with a drug need. I have to pay some huge credit to the police, although they're not here. But since we started the Drug and Alcohol Strategic Partnership and started working with the police almost on a daily basis, they have implemented a system where over 1,000 police officers now carry the drug naloxone, which can reverse opiate overdose. That's actually the highest density of police officers carrying naloxone in the country, and is seen as a beacon of good practice by the Home Office. That work in itself has saved 11 lives in the city, where police officers have attended individuals either in their house or on the streets who were clearly overdosing and have administered naloxone and saved those lives. So some of the work, although subtle, I'm not going to go through everything that's been done and achieved, because there's a fair bit. We're talking about life-saving, reducing crime, and increasing the just the fabric of society. Next slide, please. Some other progress. We've had a 9.6% increase in numbers of adults in our accessing treatment over a 2-year period, which is significant. 36 county lines have been rolled up or shut down over that 2-year period. So that's 36 drug supply chains that are exploiting vulnerable people, exploiting drug users, and exploiting children in the carriage of those drugs. And as I said, 1,030 police officers have been trained in the use of naloxone, and it's been used 18 times across the county, in the city 11 times. I think this map just summarises some of those progress measures. It's very detailed. Bear in mind these were taken from a government or a report that we submitted to government on the progress, so apologies for the level of detail. But please feel free to read it outside of this presentation. I don't expect you to observe and take in this detail. And I think the next slide similarly captures the progress that we've made in more detail over the last 2 years. I think that will do, if that's okay.
Thank you, Richard. That was very rapid and very succinct, as we might expect. Thank you. Just to remind the board that the request here to note the progress of the DASP in delivering against its strategic direction and joint priorities in relation to tackling the negative impacts of drugs and alcohol in Derby and Derbyshire. I mean, I have read through this. I'm going to read through it again, actually, because there's so much in it. But there is so much in this, and it's such an important issue. It's another really important issue. So I'm going to shut up there and take questions. So first of all, I'll go to...
Really good to hear the progress. Is there a reason that the voluntary and community sector haven't been involved in this? Because obviously if we're looking at this from a whole systems approach, we've got lots of specialists out there that could have some real significant added value into the process. So I guess it's, you know, can we have more of a joined up whole systems approach to dealing with it, and would that be valuable? And is there an opportunity to support that? So more than happy to support if we can, if that would be welcomed.
I definitely welcome some support. The constitution of the DASP and Combating Drugs Partnerships is prescribed by government and doesn't include the voluntary sector. That doesn't mean that below that there's an architecture that could include, because there are many subgroups. If you think about the DASP as an entity, beneath that is a place-based for the city and the county strategy group. Beneath that are numerous subgroups. So there's definitely a place for individuals to contribute and take advantage of those skills. But much to our annoyance, the constitution of the DASP is prescribed by government.
Okay. Sorry, can I have a follow-up question, please, Chair? It seems somewhat short-sighted in terms of having a strategic sector at the table that I think could really support that, given, you know, there's some real hands-on experience there. And I think it's great that we've managed to include throughout, but again, if we're really looking at working together for a systems approach, I just think it's important to be part of the strategic discussions as well as that operational work going on below it, I guess.
Yeah, I know your frustration.
Thank you, Kim. Did you turn your mic off, Kim?
No, I'm turning it off.
Okay, Amjad's your mic. Amjad is your mic man, I can see. Yeah, thank you. I think that is a fair point, Kim. Unfortunately, you know, as Richard said, if it's prescribed by government, there's not a lot we can do other than potentially feedback at some appropriate point when anybody's listening that it may be beneficial to extend. I mean, I know that Richard is very keen, aren't you, Richard, to have all the partners there, because it's more of a delivery operation than this board by far, isn't it? And you are very keen.
Very much so, to the extent that we invited the lead for the Joint Combating Drugs Unit, which is the government's coalition of ministerial departments who oversee the drug strategy. We invited them to Derbyshire twice to register some concerns about the way there's a disproportionate emphasis on other organisations. For example, the NHS don't get the level of scrutiny that public health get or the police get. They didn't come. We also invited that same unit to commission research, to research us locally and how we could be improved. That research has taken place, and we recently had not like a stakeholder event, but it was called a participatory mapping workshop in the county, where some consultants came over and helped us identify gaps in our system. As Councillor Martin says, it's not within my gift to decide who attends. It's very much the government's behest.
I'm always happy to help write to the government as chair of the Health and Wellbeing Board with a request. So, I mean, I'm not, as I say, I don't have a direct line to Wes, but I'd certainly, writing to the department, I think, can build a picture if various systems do it. So, thank you. So I've got Councillor Kerr.
Well, my first question was also going to be about the role of the voluntary sector, particularly in terms of Alcohol Anonymous and Narcotic Anonymous groups, which operate in Derby, but you know, they don't seem to be there. I wonder whether you can have an observer status for one of Kim's team to come along to your meetings, even if they can't be a member of the board. Maybe where there's a will, there might be a way. But my other question was going to be the role of schools and education in schools, rather than specific visits, but making sure that young people grow up with an understanding that these things that might seem very attractive to them are not going to be better for them. My son went through a slightly rebellious time at one point, and he was also keen on football. And I said to him, look, if you want to be able to play football at your best, you don't use these substances, because you've got to look after your body so that it can do the best for you. And he didn't go off the rails, he didn't do anything wrong, but it's not every parent who will be as clear or get the right message across, but I think it's something the schools can do.
Okay, yeah. In respect of your first point, the prescription of the constitution of the DAS, let's not confuse the role of the DAS is just like an executive architecture that takes the government strategy and makes sure that key partners deliver. So below that, there's absolutely roles for others to be involved in large measure. The function of things such as Alcoholics Anonymous, that they fall within the strand of the treatment, so that's embraced, but they wouldn't sit at the DAS. So in the same way, we don't have other providers sat at the DAS meeting. It's for people like myself and my counterpart in the county to go away and then speak and buy. Well, my specific skill is to buy treatment, drug and alcohol treatment, whereas the police have a specific task in designing out crime, etc. The architectures beneath that are where this conversation takes place. But at that level, it's very much a case, and Castle Martin sits on the DAS, it's very much a case of holding people to account who aren't there. Without getting into that debate, there are people who should be there, who are prescribed to be there, who aren't there. So there's a conversation that takes place regularly about levels of accountability and transparency. We are working, answering your second part, we're working towards the prevention agenda in relation to children and young people in schools. The school estate has largely not been there for a few years for whatever reason. And we again wrote to the government and asked for guidance and toolkits in order to establish better partnership working in relation to prevention of substance misuse and education in schools. They, I think, ultimately published a guide, but didn't want to get involved in mandating through departments who should attend. The reason I say that is that myself and Robin get letters from the Minister for Public Health on a regular basis and from the Office of Health Improvement and Disparity saying, we want you to do this, this and this in relation to treatment of the DASP. No other partner seems to get that. So the Minister doesn't write to the police and say, you should be there, you should be cracking county lines. So there's a disparity between the emphasis at the ministerial level. So that plays out at a lower level. So if that Chief Constable's not getting a letter saying, why aren't you at the DAS, then the Chief Constable doesn't attend the DAS. Then we have to use levers and good relationships in order to secure attendance. It doesn't run as smoothly as I maybe portray. It's 10% of my life is spent chasing partners saying, can you do this, will you do that? I need to report back to the government, we need to survey ourselves, audit ourselves. So it's quite a complex partnership dynamic.
Thank you, Richard. I'm going to bring in Sharon.
Thank you, Chair. So for the schools, we have a RHSE curriculum forum. So all RHSE leads in the city, within each and every school, are engaged in the development of an RHSE curriculum, which should include prevention around drugs and alcohol. So all that needs is a bit of knitting our end to make that happen. But public health, children's play an active role in the development of our HSE curriculum work. So I don't think it's something that we can't bring in to the conversation and make sure that all schools are able to deliver confidently and competently an approach to resilience and drugs and alcohol.
Thank you, Sharon. Thank you for that offer. I'm sure it is really important in schools because although, frankly, there's often a resistance in the short term to good advice from young people in schools, isn't there, sometimes? In the long run, the messaging stays and stays with people, I think. So we have a duty to inform people of the dangers, don't we, regardless of whether they're necessarily... we do live in a free society still, so people do have agency, they do have free choice, long may that last. But at the same time, I think there is a lot of misconception now about the dangers of alcohol in particular, isn't there? Anyway, that's just a little comment from me. Any further questions or comments on this? No, I would... so thank you, Richard. we know that the work that you do, the team and the DAS do, is very important. I can see that it's having really, really a good effect. I've got a couple of very specific questions, but to be honest, I think I'm going to ask those when I meet you soon, because they're very, very specific about some things in the county, and we are the Derby board, so we don't compare and contrast, do we, because city and county in those ways, so I'll do that with you privately. But I think this is an excellent report, thank you. Again, I think if there's any specific asks you have, is there anything further you'd like from the board right now?
No, thank you.
Well, I'm sure if there is, all you need to do is contact Alison, come back, and people will be very supportive of this work, because I'm sure there can't be many people in the room who don't enjoy a drink. There will be some. But it is a very serious issue, and it's having such an effect on, as you say, crime, so many things. We need to try and address it, and we were always on the wrong side of average in Derby, sadly. Thank you. We are going to run over time, but I'm going to let you come in very quickly, just very quickly.
It's just a small point. I think I'm biased because I'm from the university. There are lots of programs that are going on in this house that, and we have a university just on our doorstep whose speciality is to conduct evaluation to see whether the programs that we have are working as well as we wish them to. So that's just an appeal.
Thank you very much for that. Thank you. Okay, well, thank you all there. Let's move on then. We are running slightly over time, but not to worry. I'm not worrying about it today. I've got Owen, and I'm glad to see that he's bringing an update on the Derby Place-based approach partnership. Owen Swift, thank you.
Thank you, Chair. Yeah, Owen Swift, Head of Climate and Active Environments. So I'm here today just to provide an update to the Health and Wellbeing Board and an overview of the progress made to date on the Place Partnership expansion work in Derby that we are delivering in conjunction with Sport England. We came to the Health and Wellbeing Board back in May 2024, so this is to provide an update in terms of the work that's happened subsequent since then, and also what we are looking to do over the next 6 months as well. So since May 2024, when we were on the journey with Sport England, at the start of the journey with Place Partnership work, that was about developing an award or a submission to Sport England for a development grant to help bring in some additional capacity to help us develop where we think we are as a city and as a system, and working with partners to think about then what types of resources, capacity and capability would need to then start to deliver against our priorities. So what we have done since May 2024 is we have developed the Place Partnership Leadership Group, and that's been established, and there is a monthly programme meeting for that. The representatives of that leadership group, we have Active Partners Trust, Sport England, Community Action Derby, various Derby City Council services, including public health, neighbourhoods, climate and active environments, the Hospital Trust, and also Joined Up Care Derbyshire. We currently do have a representative from the ICB on that group. However, they are due to leave their current post towards the end of April, so we are working with them and the ICB to identify a replacement. Following the establishment of the leadership group, in November 2024, we delivered an initial 2-day systems leadership programme where we brought together over 50 individuals from across different organisations from Derby City Council services and partner organisations. The aim of those 2 days in that programme is to build and strengthen leadership capacity and to facilitate change across the system in a way that addresses inequality in activity. Further, we've also brought in some additional capacity to help support this work through the recruitment of a Derby City Place Partnership Lead and a Derby City Health Lead to provide capacity during this initial development phase for where the work currently is. Moving forward, and the proposed actions for the next steps for the next 6 months are we will be seeking to develop an evaluation and learning plan and framework for the work, and that will be submitted to Sport England along with a first 6-monthly evaluation and learning report to Sport England. That is due in April 2025. We are working to establish a subgroup as well, an evaluation and learning subgroup, part of which the key responsibility or key outcome for that work is helping us make sense of what we've already got collectively in the city, because we have a lot of data, of which we've seen lots of data today, lots of intelligence, lots of insight, and how do we start to bring that about, and what we're learning from that, and how do we use that to inform action. And I suppose the other thing to mention as well is that we are also in the process of formalising the governance arrangements for the work as well, and have identified and agreed a senior responsible officer for that work. And as part of that work, we will also be looking at the naming of what we're actually titling this work. And because nationally, this programme delivered by Sport England is Place Partnership. However, place has very, very different meanings in different sectors, different connotations, different spaces. And so there's an ambiguity there. So we'll be seeking to rectify that to try and reduce that locally, because clearly that means different things to different people, depending on the organisation or sector you are representing. We will also be developing a baseline and identifying the priorities for the work in Derby by conducting a systems maturity matrix. That systems maturity matrix will involve in-depth interviews conducted by an independent researcher, with baseline interviews conducted between April and May. Following that, there will be a feedback and sense-making session from those interviews with a larger group in June. And the aim of that is the interviews will provide an element of depth around where Derby currently is in terms of a system to support reducing inequalities in activity. The sense-making session will be with a larger group where the breadth of those interviews and the high-level outcomes, if you like, or themes from those interviews can be discussed and further developed. The aim of that will then develop our priorities for the work, of how we want that to play out in Derby, and we will develop a theory of change that will then be used to inform the work. The theory of change and the priorities are really, really key pieces of work, as that will then enable us to determine what our priorities are for the work moving forward, and the types of capacity and resources that we will actually then need to have to deliver that. And at that point, we will then be in a position to go to Sport England and have a conversation about the types of investment that would potentially come into Derby City to allow us to do that work. In addition, we will also be delivering the first follow-up session from the systems leadership that was delivered in November. So the aim of that systems leadership isn't just to do 2 days of training for the individuals that attended. It's about what then happens thereafter. So there's a regular coming together of those individuals to think about the learning or the knowledge that they may have acquired from those sessions, how that's then actually impacting or affecting their work in their day-to-day. And then that can be refined, refreshed and discussed at a quarterly period. So actually there's a constant learning cycle that's going on from those initial 2 days. In terms of the recommendation for the report, it was to ensure that the Health and Wellbeing Board is kept up to date on the work of the place-based partnership expansion work in Derby, and including in that the work that's happened since May 2024 and the short-term next steps and actions. Thank you.
Thank you, Owen. That is very succinct, which is a fortunate situation given the timing. It's really good. I couldn't agree more on the name. It's very, I mean, it's elusive and perhaps, I don't know if it's euphemistic, but it's certainly elusive. There's place-based partnership. It doesn't give it any sense of what, I mean, this is fundamentally a project to get people moving more, isn't it? Especially people who never move, which we received your very good presentation on last year. So definitely needs a name change. It needs to say, you know, what it's doing on the tin or something, or whatever's inside the tin. It needs to be clear on the outside of the tin, I think. Otherwise, it will get lost in this plethora of references to place. It's more about, I don't know, I'm not going to suggest titles, but we need a new title. Do we have any other comments on this work? Amjad?
Just a quick comment to say that we welcome the work. Really exciting time for us at the sector, and probably the first time we're seeing some alignment happening, especially when we look at the wider determinants of health. So really looking forward to the maturity matrix, and exciting time for the city.
Thank you, yeah, and I look forward to the update, which I hope we're all going to agree to this recommendation in 6 months' time, Owen, when we've got more, language and content that's kind of excited about what it's, about, rather than these very sort of formalistic terms around the structure of it. But I know that's all very important. But we want to see, want to envisage some of the outcomes, which I think are exciting. And then it was Councillor Kerr.
Two things. I was wondering what the funding split is between the revenue and capital. And I think this is another example of where clear integration and embedding the thinking, when it's sort of slightly more fleshed out, into everybody is going to be absolutely vital to be able to deliver it, which is when knowing what the sort of finance that would be needed and whether that can be forthcoming is going to be important as well.
Yeah, thank you. In terms of the revenue capital, it's predominantly revenue with maybe some small elements of capital. And I think in terms of the second point, yes, absolutely connected. And we know, I think, as from the presentation that Andy delivered previously, systemic work, it's really, really complex. And there is that sense that it's everyone's responsibility in terms of these big challenges, be that obesity, physical inactivity, etc. But there's also the danger sometimes that it's everyone's responsibility and no one's responsibility. And I think that's one of the key things really in terms of what we really want to try and discover through this discovery phase of the work is exactly the types of capacity and capabilities that are needed to make it. So it is someone's responsibility that can help drive the collective forward. And I suppose we've badged that or titled that as the engine room, because we recognise that there is lots and lots of great work happening in the city, but how does it get connected, how is it connected, and what type of capacity is needed to support those individuals doing that really, really good, fantastic work to bring it together so there's better collaborative capacity that happens as a result.
Right. Thank you, Owen. Well, I think we will look forward to the update in 6 months' time. I'm conscious of time, so I'm going to move on now, if that's all right. Thank you. We do have an update, some very quick reports now. Just an update from the Derbyshire Health Protection Board.
Thank you, Chair. I'll be really brief. It is for information only, and Robin would normally provide a little bit more information than is in the report, but I'm afraid I'm unable to do that. Obviously, the key headlines that Robin wanted the board to be aware of are highlighted in 4.1. If there's anything anybody wants to ask or me to take away, I'm happy to do that and kind of come back to colleagues.
Any comments at this point? It's also always possible to contact Alison outside the meeting at any point as well. So no comments on that. Thank you very much. Thank you for that. So the joint local health and wellbeing strategy update development, Alison.
Thank you. And again, it's for information, but just gives the board an idea of kind of what we're doing within the working group to progress the joint health and wellbeing strategy. And I think you mentioned kind of food earlier as an example, Chair. But in terms of, I think, focus and discussion that we've had in terms of understanding what do we mean by health and wellbeing board, I think it was really the wider determinants and kind of the drive and impact of those that have been really strongly coming through. We have kind of re-looked and rechecked the requirements that we need to have to make sure that we do cover those. I think one of the things that came up that we're wanting and we're in the progress of doing is trying to understand and map kind of the other strategies and work that's at play within the system. So an example I think you referenced earlier was the anti-poverty strategy. So trying to map and understand kind of what the system and structures look like that could inform and be part of the contribution of the health and wellbeing strategy. But also thinking around what consultation engagement work that has already happened that we can really understand and build on and kind of put that within the strategy development, but also then recognising where we've got gaps that we might need some additional work. So the next steps are to really pull a position statement together in terms of where we are really setting out the scope, the key areas of focus, principles, potential measures and interdependencies, but really kind of doing some work in the background, as I've just mentioned, around some of the mapping work around strategies, the consultation and engagement, but also looking at measures and activities that are happening in other areas in terms of being able to understand if we're how we make or able to assess kind of whether we're making an impact. So the kind of works that are ongoing, and that group is continuing to meet monthly to progress that work, and obviously we'll continue to update the group and hopefully bring you back something that's starting to look like a strategy at some point in the near future.
Thank you, Alison, and thank you to everybody also that's involved in that work. And it is good to see that employment, we've had approaches from the DWP about potentially joining the board, so that could be a beneficial move, and I'm glad to see employment on there. But I just got one very quick comment, and I probably can't discuss it now. So I think that all of these factors are really significant, but a kind of an overriding factor would be socioeconomic status that we don't have in there. If we're looking at wider determinants of health, I would say that, particularly in terms of health inequalities, I would say that is well, the prevailing determinant. So that is something I'd like to see added. But I know you will bring it back and we can have a proper discussion. But it is something that just strikes me as, whilst all the others are really valuable, that seems to me an absolutely key one. Any other comments on that now? Thank you.
Oh, okay. That's item 11. Yes, thank you for raising the matter, the issue of socioeconomic determinant and health. I do think that is an area ought to be looked at separately from inequalities. I think we ought to stop conflating all inequalities in that way. It doesn't give us the granulation that we need in terms of data. Could we also add to this maternal health, maternal care? We are aware that black and ethnic minority women are 4 times likely to die in childbirth and have bad maternal experience, and I experienced bad maternal care about 34 years ago, that I almost died. I went into a coma, and there are several others that I know had bad experiences. So I just wondered whether that could be added to some of the areas we're looking at.
Thanks, Councillor Wright. You raise a really important point. I mean, we can debate and discuss in greater detail the categorisation of socio-economic determinants and health inequality at another time, I think. But just in relation to that, I think you do raise a really important point about maternity services. We know that there have been problems at our own many maternity hospitals. Anyway, regardless of the ethnicity factor, which I know is significant for the black community. We know there are huge problems in Nottingham, and the whole health system in Nottingham is receiving incredibly bad press at the moment, what with mental health problems. And so, and we know we've had problems in our own Royal Derby Hospital, so we wouldn't ignore those at all. I think that is something we could bring, and we have had a recent report on infant mortality. Maybe there's a connection there. We don't know. Hopefully the report on infant mortality will look at to what extent that higher figure in Derby is influenced by the poor service that has happened recently at the Royal Derby. But I think that could come under the category of health services, which you've already got in there, haven't you, Alison? So, but we will look at that. Thank you, Councillor Wright. And the very last item, we've already done, you'll be glad to know, the action plan, so it's just the forward plan, Alison.
Thank you, yeah, and just to note that we've got on page 2 kind of the outline agenda for the next 2 meetings, so it's just for your information, and I think you mentioned earlier, but just to reiterate, if there's any other items that members would wish to come to the board, then just let me know.
Yeah, it's quite a simple process that all partners, both statutory and non-statutory partners, can feed into the agenda and should do so directly to Alison, and that Margaret and I can discuss that when we have our agenda setting meeting. So just to reiterate that, thank you very much. So at that, thank you ever so much for coming, actually. I can't believe we're only 8 minutes over time. 8 minutes is still not dignified as a chair, but I find what we're discussing so compelling and so important. Thank you for your patience. Thank you for coming, and we'll see you next time. Thank you. Bye.